Welcome to Advancing Health. Improving maternal health takes more than one type of provider. Learn how multidisciplinary teams are breaking down silos to support healthier pregnancies and better outcomes.
Welcome to Advancing Health. I'm Julia Resnick, Senior Director of Health Outcomes and Care Transformation at the American Hospital Association. I'm here with Kardie Tobb from Cone Health. She's a cardiologist and works on obstetrics, and we're going to talk about team-based care so that women can have better pregnancy outcomes. Kardie, thank you so much for being here.
Thank you for having me. It's such an honor. I am looking forward to this conversation.
Same. Can you tell our listeners a little bit about who you are and your role at your hospital?
Sure, of course. So I am a trained cardiologist, a preventive cardiologist. I focus on women with cardiovascular disease in pregnancy. So a term that we call cardiobstetrics. And I am in Greensboro, North Carolina. I work with a health system here, and we have been able to be fortunate for me to lead our initiative to develop our cardiobstetrics program. And it's exciting to be able to work across dimensions of health specialties with the OBs, our maternal fetal medicine specialists, anesthesiologists, and our nurses, and take care of patients to make sure they're having better outcomes.
So, cardio-obstetrics, I think by nature, is kind of an interdisciplinary model of care. So, can you talk about how you're thinking about that level of team-based care and really what prompted you to redesign how pregnancy care works at your hospital?
So let me tell you, it is really everything stemmed from looking at what our national data is showing. Maternal mortality, we're in a crisis. And in different pockets of where we are in the country, we have to be thinking along the lines of team-based care. So when I started fellowship, initially I thought I was going to be an interventional cardiologist, and I was feeling pretty good about that until I started to look at my mentor who was in women's health and started to look at the burden of women with heart disease in pregnancy and thought that I was going to pivot. And I'm so glad I did, because now I have a fulfilling career where I not only care for these women, but I have colleagues that we think about it together. So at Cone Health, with our interdisciplinary cardiobstetrics team, what we have is a team of people: OB, MFM, anesthesiologist, pharmacist, social worker, nurses, that we really discuss what the outcome or what that delivery plan and what the care plan is during a pregnancy of a woman who has high risk cardiovascular diseases. By that, I mean like women who've had a heart attack, who've had heart failure, who've had strokes, who actually have high chronic hypertension that's really not controlled during our time, diabetes, and you name it. And we really do a good job to talking to each other. I'm really intentional to say talking to each other, because all health systems have cardiologists. Most health systems, I should say, because some rural hospitals may or may not, have OBs, have anesthesiologists, but most of them work in silo. And that's why I'm so proud that with our cardiobstetrics program, we're able to have this interdisciplinary conversation that we can make sure our patients are well cared for.
That's fantastic, and especially, knowing that cardiology issues are one of the major causes of maternal morbidity and mortality, like, it makes so much sense to start there,
It
and
is. It is. For many years, we've had the traditional care where we think reproductive care years and pregnancy years is for the OB. But what we've seen now, the trend with women having babies in older years, some of them have developed heart disease, some of them have inheritable heart disease, some of them have congenital heart disease. It's a problem. So, cardiologists, we need to understand that this is our problem too to help solve.
right, and I think, like, we've been hearing that so many women are sicker when they become pregnant, which just means that their pregnancies are higher risk for themselves, higher risk for their babies. So, like, how can we think more holistically about, like, preconception care to put women on a pathway to healthier pregnancies?
This is one of my advocacy, Julia, to be honest with you, because a lot of time we now think about the pregnancy care, and we don't think about the mother before the pregnancy care, and we don't educate women enough for them to understand that they need to declare their intentions of wanting to give birth. Because once that's known, and we don't also talk enough with the primary providers to help women declare their intentions of being pregnant. Because once the intentions is known, the rest of it is easy because then you start asking questions about family history, about the woman's own history. So imagine a 42-year-old woman who desires to get pregnant but was diagnosed with high blood pressure 10 years ago and may or may not be treated. And she wants to have a baby. She needs to know that we need to look at those blood pressures, needs to know that her blood pressure needs to be optimized, as opposed to she gets pregnant. She's very happy because she's planned that she's planning her life. She's planned her career and now she's starting her family. And then by her 12th week of pregnancy, her blood pressure is 160 over 90. That is devastating because there's a risk that she could lose the baby. And there's also that problem that not only losing a baby, her complications that associated with it, not just during that time of the loss or the potential loss, or during that time years later. So we need to, it should really become a part of how we care for reproductive women, asking them about declaring intentions. Because there are some women who don't want babies, and it's okay.
Absolutely. And I feel like we're going to become evangelists for this. Like, how can we better educate women about their health before they get pregnant to set them up for a lifetime of health, whether or not they decide to have a baby?
And I will be there with you, trust me, because the advocacy, and I think that I have dedicated my career to just this one thing, making sure that women understand their heart health, their overall wellness. And then when it comes to trying to have a baby, we need to, as a country, not just as where I practice Greensboro, or not just as Chicago or Philadelphia or Alabama, we need to, as a country, start thinking about the wellness of women health, period. There's been a huge transformation in the education of women across the country, but there's still a lot of work to do. Because when we see women, sometimes we think breast cancer, number one killer, but that is not true. Heart disease, number one killer. Reproductive years, heart disease, number one killer. Leading causes.
Yeah. And when we think about young women, they usually think that they can't have heart disease because they're too young and they're too healthy. But that's not true.
That is not true. Young people in general feel that we're indispensable. We're not. There are lots of ways that young people can have heart disease genetically, high cholesterol. Thinking about heart disease that are inherited genetically. So I think it should start from the younger years because people are thinking that heart disease is not something for the young, especially in women. We look at it in postmenopausal stages. That is not true. We start from a younger age, knowing the blood pressure, thinking about if you want to have a baby, what that desire for your blood work and things like that.
I do want to go back to the pregnancy conversation. So, from the patient's perspective, when they're part of this interdisciplinary model of care, who are they seeing as part of their care team, and how does the flow work for them, and how does it differ from traditional pregnancy care?
So the OB is the driver of the care team. The OB is the one that's going to identify when cardiology come in. The OB is going to identify when a behavioral specialist come in. So it's almost the OB is our captain of the ship. But being in that model where we're not siloed anymore and we're making sure that the patients know when they need to be referred, the patients are screened. And I think the big part of that care model is not necessarily always seeing the patient, but always having a conversation during those roundtable because we can't have a multidisciplinary clinic in all states or all places because when you think about the payers and all how that work, but we can have a roundtable where we can discuss every patient, every problem, and come up with a joint solution.
And can you talk more about those roundtables and who's involved and how that guides care?
So what happens, we identify patients based on their history, what they have, and a lot of times that identification comes from our OB team. And sometimes if they see a cardiologist first, like myself, and we have a group of a list of those patients, and then who's on those roundtable discussions are the cardiologist, the sometimes our advanced heart failure team members because we have women who EFs are low and need advanced heart failure, our pharmacist, our obstetrician, gynecologist, our maternal fetal medicine team member, our nursing leaderships from the discharge areas to the labor wards, our social workers, our pharmacists, and we pull people in as we need. And what we do, we look at the individual, we look at their chronic disease processes, we look at what is needed in terms of clinical care and social needs. Not just we think about it as providers, doctors, and we say, oh, this is what we know. We look at it from a holistic standpoint. What they need to have a safe delivery in terms of treatment prenatally, and what they need to have a postpartum stay and be very comfortable at home and making sure they're not leaving their baby to come back for a readmission.
That's incredible. And I just want to close with your words of advice. So if our listeners were to take one action to think about how they could improve pregnancy outcomes for women in their communities, what would be your one piece of advice for them?
So I'll start from an enterprise level and talk to healthcare executives and say, from the care of a pregnant woman or a reproductive age woman is not based on the OB or the nurse. It starts from the CEO who really pushes the initiative of making sure that we look at data on maternal health, not just from the race, ethnicity, language, make sure we understand the gaps and really build bridges to help close those gaps. And then I'll talk to the clinicians. It's not about us as physicians or providers. It's about the patient. So we need to align and have conversations with our other subspecialties to make sure that we're aligning on better outcomes and not work in silo. And then I would talk to the patients and say that have a conversation with your provider. If you're a reproductive age woman who wants to have an intention of having a baby, who wants to be pregnant, understand your health, because a healthy woman would carry a healthy baby. And once you can do that, push until you find a person who's going to help you. And then optimize your health if you have chronic disease before you get pregnant. It makes for a much more healthier pregnancy.
Those are wise words for leaders, providers, and patients. So, Kardie, thank you so much for joining me for this conversation. I am so inspired by the work you do and look forward to seeing how it continues to develop and grow.
Thanks for having me. It's always a pleasure.
Thanks for listening to Advancing Health. Please subscribe and rate us 5 stars on Apple Podcasts, Spotify, or wherever you get your podcasts.